All right, so why don't we go ahead and get started. I'll give the last couple of people a chance to sit down with their lunches, and I did want to remind everyone to turn off their cell phones so there are no interruptions during the talk. So I have the great pleasure of introducing today's Grand Round speaker, Dr. Lisa Dixon. Dr. Dixon is a psychiatrist, professor of psychiatry at Columbia University Medical Center, where she directs the Division of Behavioral Health Services and Policy Research. She also directs the Center for Practice Innovations at the New York State Psychiatric Institute. And through this, she oversees activities for the New York State Office of Mental Health in implementing evidence-based practices and behavioral health programs throughout New York State. She's an internationally recognized health services researcher with over 200 publications in peer-reviewed journals. And her research is focused on improving the quality of care for individuals with serious mental disorders. She's been a pioneer in services for families and also interventions to reduce the negative impact of co-occurring substance use disorders and medical illnesses. As most of you know, she's the editor-in-chief of the Journal of Psychiatric Services. Dr. Dixon was the PI of one of the 2 NIMH-funded RAISE studies for coordinated specialty care for early psychosis. And her implementation and evaluation study examined the best way for clinics to start using coordinated specialty care. So we're very excited to hear from her today about that experience. She currently leads OnTrackNY, which is the statewide initiative for treatment of first episode psychosis in New York State. So her talk is titled Early Psychosis Treatment, How Did We Get Here and Where Are We Going? Dr. Dixon.
Hi, everybody. Good. Well, we're just at the cusp of morning and afternoon. So happy morning and happy afternoon. It's a pleasure to be here. I have a lot to say, and I'm a New Yorker, really. So even though I've spent most of my career in Maryland, so I'm going to go fast. I'm really pleased to be here. As I was saying, your department and your kind of community is, now I would say known throughout the country and the world as being one of the premier departments of psychiatry. And so I'm just very happy to have the chance to share some of my experience with you. I start with my disclosures. I'm going to be talking a lot about OnTrack today, which is New York's early psychosis program. And, we do provide some training, although nobody in the group personally benefits from it. But when I give my disclosures, this is really the more important disclosure, and kind of explains a little bit of kind of why I'm here and who I am. This is my family. I have a pretty serious case of chapped lips in that I'm the little girl in blue there. And you can see from the hairdos that I'm old. Why do I show that picture? I show that picture because when I was in high school and college, my brother, who's a little older than me, developed schizophrenia. And he has had a really, really challenging course. He and I were very close growing up. I was, we were like the younger part of the family. We did a lot of 2-on-2. It was my 2 older sisters and then the 3 boys and me. And he was my bridge partner, my basketball partner, everything. And his life really, unfortunately, unraveled around the time of college and actually medical school. He was able to get into medical school, but was not able to complete it. Here we are again. Some of what I bring to this is my own personal experience. So this work is, this kind of work, the story that I'm going to tell is really the product of just an enormous number of people's work. And so I can't even begin to list them all, but I just want to acknowledge the team. And, for me, this is it's a very, there's so many things I could talk about with first episode, but I think what I want to do is to share with you, to have you by the end of this appreciate that we're at a little bit of a turning point, that I've been doing sort of dissemination of evidence-based practices for my entire career for 30 years. And I can tell you, I have given more useless talks than probably anybody. In fact, I gave a talk when evidence-based practices fail, what next? That was one of in the series of talks that I gave. But I find myself now at a time where suddenly something is happening, where something is changing, and something has changed. And there's a lot of reasons for it. And I kind of want to, in the first part of my talk, I'm going to try to tell you that story. I'm not going to have more than 10 minutes to tell it. And then I'm going to go into some of the science and sort of some of the challenges. But there's, why don't I fly all the way across the country other than, to see you guys and to see my daughter on the way back. The reason I flew all the way across the country is because I think this is, there's a lot to be learned here about change and transformation of practice. So I wish I had a little bit more time than I do have. This is the screenshot from a video that was made actually by a woman who's a producer who lives with mental illness, and she worked with my team to make some videos of some real stories of patients who received services from OnTrack. And if this is something I can send the links after. We actually now have to blot out the images of some family members that haven't given us permission. So anyway, Sebastian, it's an incredible story of a young man who is a student at Syracuse. He's a jazz guitar major, and he developed schizophrenia. He developed psychosis actually in that summer between high school and college. And this is a 5-minute video in which he shares sort of his story of what it was like when he first got ill. And he's been with OnTrack for a little bit less than 2 years. And his recovery, and then he plays his music, which is awesome. So, but again, the idea being that a very important part of this whole kind of new way of thinking about and working with people who have schizophrenia is that it is in fact not an illness that people have to be sentenced to a lifetime of disability and dependence. And obviously, it's a very heterogeneous disease, and we'll talk about that. But this is this video, which is the story of Sebastian told in his own words and his mother's words. Okay, so my talk is going to be divided sort of into 4 parts. The first is going to be kind of the how did we get here, very much a political policy type of story, and with a little bit of science and a little bit of advocacy. And then I'm going to be sort of in as concise a way as possible, trying to sort of share with you what I see as kind of what are the foundational, what do we know foundationally about the service, where we are in terms of services and scientifically, and what are the unanswered questions. Okay, so when did this start? And sort of thinking about why are we here now? We always have to have a context. So let's bring ourselves back to 2005, which is like, oh my God, it's like 12 years ago. It seems like it was yesterday. But let's go back there, and we need to appreciate that many countries in the world were really, early intervention was a part of their way of delivering services, or at least conceptualizing how they delivered services, primarily countries that had more of a centralized healthcare system. But we were very far behind, okay? And this is really sort of the context out of which RAISE grew, the studies RAISE. And so why did that happen? And this is where I'm going to challenge one of my mentors, Howard Goldman, who's a historian. And what he would say is that there were these sort of cycles of reform, the most recent of which was this community mental health center movement of the mid-20th century that sort of promised prevention, that promised early intervention, and which actually subsequently failed, which didn't achieve the promise. And actually, it is a risk that we face today. And that failure kind of led to a backlash, and sort of the accusation of the system in the 70s that the system had sort of abandoned people with chronic illness, with established disability. And so there was kind of a return to kind of an investment in resources to people with, what we call now SMI, serious mental illness, people with longstanding illness. And then the rise of Medicaid, interestingly, in many states, which, you needed to be disabled to get insurance coverage, sort of contributed to sort of this focus on people with established illness and a focus away from early intervention. And that's a little bit the reason why, why we kind of in some ways fell behind. And actually at the same time, also around that time in 2005, we had what's now called AHRQ, or the Agency for Health Research and Quality. The AHCPR began to fund these PORTs, patient outcomes research teams, which were sort of these entities that established what was an evidence-based practice. And so I was involved with my mentors, Tony Lehman and Howard Goldman, on the first PORT in mental health, which was focused on schizophrenia. And so we were beginning at that time to sort of say, oh, this is an evidence-based practice. And now we think, EVPs are like, well, everybody knows what an EVP is, but that, the notion of evidence-based practices is not necessarily, it hasn't been around for that long. And so this was in the air, this notion of evidence-based practices for people with schizophrenia. And so out of that morass, at the NIMH came RAISE. RAISE stands for Recovery After an Initial Schizophrenia Episode. Who here has heard of it? Okay, so most of you, but not all of you. Okay, so this was an initiative of the NIMH. And the initiative, or the RAISE, had a very, very ambitious agenda, okay? I'm going to read it to you. The Recovery After an Initial Schizophrenia Episode initiative seeks to fundamentally alter the trajectory and prognosis of schizophrenia through coordinated and aggressive treatment in the earliest stages of illness, okay? So it wasn't just, we want to do a study that's going to, increase people's or decrease people's PANSS scores by, 2.5. This was an effort that from the beginning wanted to change the course of illness. And again, this was a contract. The mechanism through which investigators could apply was a contract. So it was very clear. The contract had statements of work which you had to address in applying. So it wasn't a grant where you could sort of do whatever you wanted. No, this was a contract. This was the statement of work. Develop, refine, deploy, and test an early intervention model that is relevant for the U.S. mental health system, engage community treatment programs, not academic research clinics as partners, and incorporate features for rapid dissemination, adoption, and implementation in community clinics. In short, this was efficacy, effectiveness, and implementation all in one project, which was daunting, to say the least. There were two projects funded. The one that you have, if you're familiar with it, you're familiar with this one. It's the RAISE Early Treatment Program Study. I call it the Greater RAISE Project. I call ours, so it's a Lesser RAISE Project. But the Greater RAISE Project, and I'm, with all due respect, the RAISE ETP study was an amazing study. It was very briefly a national study, 34 sites, 17 sites, randomized to deliver what we now call coordinated specialty care, which I'll be telling you about, and 17 sites, treatment as usual, and the outcomes of people who receive services at the Navigate or experimental site were compared to the outcomes of people receiving treatment at the usual care sites. Our study actually was initially a randomized trial, a different design. It was a patient level randomization, but for a whole variety of reasons that I think probably had something to do with money, our contract terms were changed and we were asked to do some other things that I will refer you to, but we did not do a randomized trial. We did, however, put together a treatment program that we called Connection, and I'll again be talking about that. Okay. So this is a little bit of a timeline. Remember, this is how did we get here. So in July 2009, the studies began, okay? The RAISE studies began. We, again, as I said, we were RAISE Connection. John Kane's program was Navigate, and that's the program that you're doing here in Washington State is Navigate. So we started, we were going to be in New York and Maryland. And we did the things that we were supposed to do. They asked us to create some tools, and we did. And I'm just showing you this because there was some productivity. And then it was 2010, it was 2011, and John's study was moving forward. And suddenly, then I'm going to show you this timeline. Because this timeline, the NIMH staff who were overseeing the raise contracts, they knew that in order to change, change care and to change the trajectory, they needed to engage federal partners. Because if you're going to really change care, you have to change financing, you have to change, where a lot of the money flows. And so they were, from the beginning, they were sort of tracking how they engaged other federal partners. And this is a graph, a timeline that I actually got from Bob Heinsohn of NIMH. And what each line represents is a contact between the NIMH staff and the different federal partners. And you see SAMHSA, CMS, CMMI. And you'll notice, if you look at this timeline, that there's this red square that seems to represent a turning point or a change, an inflection in the number of contacts. So the question is, does anybody know what happened in the fourth quarter of 2012? And pardon? No, I'm not gonna torture you with it. Pardon? Yes, it was Sandy Hook. Yeah. So we live in this horrible, unfortunate world where episodes of violence that are attributed to mental illness, put us in a bit of a box, right? I mean, it can focus the attention on the importance of treatment for mental illness, and of course, we pay a terrible price in terms of stigma. But at any rate, this is what happened. And what you'll see is that then there were all these engagements. And okay, so all these engagements are happening. There's a lot happening in Washington, okay? And at that time, right afterwards, it was actually 2013, that our study, the lesser raise, we had finished. And New York, I was in New York at that point, and Mike Hogan, who was the commissioner, and this is again a story of how one person can make a difference. Mike actually oversaw the President's New Freedom Commission on Mental Illness. He had been the commissioner in Connecticut and Ohio, and then in New York, and he is also a sibling. So I suspect that probably some of you in this room are siblings or have your own kind of connection or story to mental illness. But Mike was like, we're doing this. We are doing early psychosis treatment in the state of New York. I don't need to see the results of the RAISE ETP study. There's enough international literature. We have shown that we can do it. We had a model. And actually, when I moved back to New York, and that was one of the jobs I was given, was to create kind of the roadmap for delivering early psychosis treatment to people in the state of New York. And so we came up with a name, and there's so much about branding in this work, because you have to use language that isn't stigmatizing and scary to people who you're trying to engage. So anyway, OnTrackNY York, and you see we flipped from Raise Connection to OnTrackNY York in June 2013. And incidentally, we stole a lot of the really good stuff that Navigate was doing. So it's really good when you stop doing research, then you can just, pick and choose and do what you think, makes the most sense, as long as you measure it as you go. Okay, so then what happened? All right? We enrolled our first patient in OnTrack in June 2013. January 2014, again, before the results of the RAISE ETP study came out, the president signed legislation to allocate an increased amount of money into all the state mental health block grants of 5%, which amounted to about $25 million. Every state got some money according to what their overall block grant allocation was. And this was new money. This wasn't, robbing Peter to pay Paul. And unlike the other components or the other sort of structure and rules of the block grant, this money had to be used for first episode psychosis, and it had to be used for evidence-based first episode psychosis, which nobody really knew what that was. So the NIMH and SAMHSA had to get together, which was also another unusual thing, and sort of figure out what was, and sort of communicate to the field what was evidence-based early psychosis treatment, okay? And it's actually out of that stipulation and that negotiation between, with SAMHSA and NIMH and others of us participating, that out of that emerged this new thing that they called coordinated specialty care, or integrated coordinated specialty care, which didn't exist. There was nothing that didn't exist before this legislation and this process to sort of specify what evidence-based early psychosis care is. And it was kind of, I don't know if you guys are familiar with like the common elements approach, right? So this was sort of saying, okay, well, what can we glean from the literature? What can we learn about what's effective? There's actually no real test of everything that's coordinated specialty care. It's kind of it's a sort of a make-believe model, but that builds on sort of different studies. And so again, what is coordinated specialty care? When I try to keep things, I like to have buckets. So you have the multi-element buckets. It's a multi-element treatment. What are the elements? It's got case management, supported employment and education. It's got cognitive behaviorally oriented psychotherapy. It has family education and support, and has pharmacotherapy and primary care coordination. When it was first sort of, the white paper that described this was put on the NIMH website, it didn't include peer support. Now, I mean, a lot of the programs have peer support. And then you have the elements, and then you have how they're tied together, okay? And how they're tied together is in a team-based model with community outreach, both on the front end to get people into the program, because we'll talk about DUP in a second. There's a real orientation toward engagement and outreach, and sort of the use of shared decision-making as sort of the guiding approach to make this really a person-centered model. Okay, and actually, if you want to, the white paper that's on the NIMH website is really quite a good summary of sort of, the thinking at that time. Okay, put this quote in here. So again, 2014, still no results of the RAISE ETP study, hasn't come out yet. Insel characterized the RAISE as the single most noteworthy research story in mental health in 2014. Insel pointed out that RAISE reminds us how research can be moved into practice when agencies, Congress, and states are aligned. And, as someone who sort of has spent my career carefully kind of, walking down this path of research and practice, the fact that the findings from the main study, the big cluster randomized trial, had not yet been, were not known. It's such an interesting kind of testament to both the power of research, but also the power of other things that really influence, how our care system morphs and doesn't morph. Okay. So here we are, we have the timeline. We started in 2009, December 2013. We have the RAISE feasibility study, these other things going on. And so January 2014, we have the first $25 million set aside, and then we get another $25 million the following year. Okay. And then finally, on October 20th, 2015, which I won't forget for two reasons. One was the New York Times, the RAISE John study came out. The New York Times completely botched the reporting of the findings to the point where everybody was on the phone in the morning discussing this. And a number of us were in Washington at a congressional briefing. So John, myself, Bob Heinsohn from NIMH, a family member, and a consumer were at a congressional briefing that was organized by NAMI, okay? Here, again, to sort of talk up, to publicize, to make real this movement. Okay, I'm just looking at the clock. So here you have the main findings of the primary hypotheses of the RAISE ETP study. Their main hypothesis was quality of life, which also included functioning. And here you see, thank God, there was a statistically significant advantage for Navigate. You see the orange line is Navigate, the green line is usual care. This is symptoms. You see orange line is Navigate, green line is usual care, and both were statistically significant. But you'll notice, that it's not like knock you over, right? It's not knock you over, but it was statistically significant. And frankly, at that time, it's all that mattered. It's all that mattered. Nothing else really mattered. As long as you could say they did better, less symptoms, better functioning. That was all that mattered in that sort of political context. Okay. And then that, then we had CMS getting into the fray. We have federal policy guidance to how we're going to finance this. And then, everybody had been worried that the 25 mil was going to go away and be a one-off. Okay. And so actually there were several states that were kind of reluctant to jump into the game because, why was going to happen with this? Well, not only did it not go away, it got doubled. Okay. So you had the first 2 years of 25 mil, and then that was doubled to 50 mil. So all the states, it's still not a huge amount of money, in the United States of America, $50 million, I understand that the new medical record in the VA is going to cost $500 million, but it's a start, and you'll see, how and why it was a start, how we know it was a start. And so the kind of momentum continued. And here you have, so this is my last slide for this portion of the talk. This again comes from Bob Heinsohn at the NIMH, who actually was like the quarterback tactician, having all of us sort of, calling the plays, actually. And what you see here is the cumulative number of states with early psychosis intervention plans. You see almost no states, of course, Oregon. Your neighbor was one of the, early adopters. And look at here with 2018, virtually every state. So I don't know, like for someone like me that has spent my career looking at flat lines, to see something like this, it is sort of, it's almost beyond one's hopes and dreams for how, for sort of, there isn't even really that much new science here. Honestly, but how did this happen? Okay. And so I think what I tried to sort of convey to the best of my ability was that it was this weird combination of a violent event, okay, of science, of tactics, of advocacy, of consumers and families getting in the game, all right? And we went from literally, a service system that, look, my brother has severe mental illness, and I'm all for focusing on people who have chronic illness, but we were missing something terribly important and in early intervention, and now that's starting to be remedied. Okay. So that's sort of how we got here. It's ongoing. Given what's happening in Washington now, there's, as I'm sure you can imagine, early psychosis, among other, important things, just like healthcare in general, people are worried about. But, I will say that, this is a story that continues to unfold. Okay. So now I want to just pull back and start to, kind of tell the story in a slightly different way that is useful for us as clinicians and people who deliver care and people who are organizing care. What are we building on, and what do we know? What do we not know? And what do we need to learn more about over time? Okay, because this is only the start, honestly. I think if I could convey anything to you, it's that that this is an opportunity to provide service, but also we have a tremendous amount more to learn. And we are at risk, if we do not do that, of sort of committing, of failing to do what NIMH stipulated it wanted to do, which was to change the course of schizophrenia. And we don't want to fail this time. We think we have the technology now and the tools, but that remains to be seen. Okay, so as I said, I like to divide things into kind of relatively simple things that I can understand. So I'm going to organize this kind of summary and synthesis around before, during, and after. Okay, so what is the before? Okay, the before is what happens to people before they get to first episode care. Okay, that's the before. And in order to sort of converse in the before space, you have to know about what we call the duration of untreated psychosis. All right, so the duration of untreated psychosis is the time between the onset of psychosis and the delivery of criterion care. And for most of the literature, that delivery of criterion care is antipsychotics, but not for all. So there's some muddiness about, is it a good psychosocial program or is it a treatment program? But the earlier work, I would say for the most part, was more focused around exposure to antipsychotics, which gets us into this whole issue of antipsychotics, which I'm not going to go into now, but it is sort of that this has informed the debate about the both the dangers and the benefits of antipsychotics. But anyway, so what do we know? We know that there is a very robust association between longer duration of untreated psychosis and poorer outcome, both short-term and long-term, okay? So if you take my brother, let's just make it real. He probably developed psychosis before he attended medical school. He did a year, his first year of medical school, he failed out. They let him come back and he was able to finish it on his second chance. Then he did a second year and he failed out and they sent him home. So just taking my brother's situation, he had probably at least a 4-year time period that he wasn't treated and he was actively psychotic. So this is just kind of a way to think about the pathway to care, onset of symptoms, help seeking, mental health services, and referral to early intervention services. So just so you know I'm not making this up, this DUP thing, this is actually a meta-analysis from 2005, so you can see that this is not new, this observation is not new. What you see here is, this is baseline, 6 months, 12 months, and 24 months. You see the different time frames, and then you have each of these dimensions, everything from symptoms to quality of life to functioning. And what you see here is that virtually every outcome at every time point, longer DUP is worse. 6 months, 12 months, and 24 months. It's actually interesting that it's not different at baseline, but I don't even want to go there because that raises too many interesting questions. That's DUP over 2 years. This is the association of longer DUP with outcomes beyond 2 years. All right, so just showing, and this is a little bit more of a complicated meta-analysis, but the point is that, again, there's a pretty robust association, many studies between DUP and outcome. So in John's study, they had the opportunity to look at DUP in the United States today. So 34 mental health clinics. So I usually do this thing where I make people guess what they think the average DUP in the United States is, but I didn't do that. I wasn't clever enough to remember to do that here. So the mean DUP in John's study, John Kane's study, in the RAISE ETP study, was 196 weeks, suggesting that, my brother's experience, which was frankly 40 years ago, things haven't really gotten much better. You will see that the median, of course, is a lot shorter, because of the tail of the DUP events, but still a median of 74 weeks is pretty bad. And about 70% had a DUP of greater than 6 months. So just think about the idea that the vast majority of people, think about someone walking around with a visible cancer, for 6 months, a year, 2 years, 3 years, 4 years, and not getting treated. That's what, I mean, these are not people who are like in clinical high risk, prodrome, having a little bit of depression and withdrawal. This is like psychosis, okay? Not being treated. So then we get to, let's look at the RAISE ETP findings in a different way, okay? So you remember that slide that I showed you that wasn't all that impressive? Now, let's look at their findings on quality of life, but let's divide the sample into those with the shorter DUP and those with the longer DUP, all right? So this is control, this is usual care, the green, and you'll see that dotted line is longer DUP, solid line is shorter DUP, no difference in the usual care condition, right? The curves just lay right on top of each other. Now let's look at navigate, all right? Navigate, this is the longer DUP, runs right parallel with the usual care. And now let's look at navigate with the shorter DUP. And then you start to see something that looks a little more robust in terms of the difference between navigate and control. So there was an interaction. There was a statistically significant interaction by DUP with outcome. And so, what this sort of begins to tell us is that, it's about getting the right treatment at the right time. Now, I just want to say that, we haven't randomized people, to short and long DUP. And so, there's always confounds. We have to be very skeptical as scientists, and we could have a whole discussion on what could be confounding this relationship. But I will say that Many of the studies that have looked at this have tried to adjust for everything that they can think of that might actually cause both long DUP and poorer outcome, like insidious onset. And even with those sort of controls, you still see this association. But I just want to park that idea over, because I don't want you to think that like we can't accept all, we're wrong a lot, so want to make sure that we're appropriately skeptical. This is just, I'm going to just very, very briefly, this is a study that, as I said, our randomized trial was taken away, but we were asked to do some other things. And one of the things we were asked to do was to look at to do a qualitative study of pathways to care. So we interviewed a number of individuals who received early psychosis services and their family members, and we did all the appropriate qualitative study things. And this was the model that sort of we came out with, again, from the words of people who had lived this, sort of what were predictors or factors that led to either longer or shorter DUP, and misattribution, stigma, and self-reliance, from the onset of illness, before help seeking, could go either way. And again, I don't have the time to really dig into this with detail, but I'm sure you can imagine, how stigma was a factor. Self-reliance was a little bit more of a surprise, that, a lot of our patients and their families said, well, I should be able to take care of this myself. I shouldn't need help. And so this is a situation where self-reliance, actually lengthened DUP. And it was, again, the same for patients as for families. And then after help seeking, again, big surprise, interpersonal connections, quality of care, family involvement, when families were treated respectfully, shorter DUP, when they were alienated, longer DUP, and then care transitions. And I think for those of you who live in the clinical world, this will not be a surprise. And actually, I think we have a paper that is just about to come out that will describe the results of the study that may be of interest. Okay. Okay, so that's kind of the science. What I want to talk to you now about, and for each of these before, during, and after, I'm going to tell you a little bit of what we've done in New York, so you can see how it's played out, okay? So when we're looking at the pathway to care, and we want to bring this to scale in the state, we had to ask ourselves, what could we afford, what was possible to do? And I would just tell you that, again, we said, okay, we could focus our energy from the very beginning of the pathway, which is the onset of symptoms. But at the end of the day, we decided that was going to be too difficult and too expensive to start with, okay? Because that really requires community education and outreach. And we knew, and then research had suggested that the pathway was lengthened inside the mental health system and inside the healthcare system. And so we knew, based on research from all over the world, that if we could focus here in the healthcare system, we would shorten DUP. And we could do it fairly efficiently, because we had much more access to the healthcare system. And you know what? And this was Mike's wisdom. He says, we have to win coming out of the box. You don't want to start a new initiative and like not be wildly successful, right? So this was a strategy, because this is about, recruiting public support, and it's about telling stories. And so we started on this side of on the service delivery side of the pathway. We also decided, and I think this is true of a lot of the new programs, we were only going to focus on non-affective psychosis. And again, we could have 3 hours just on that decision alone, as opposed to including affective psychosis. And we also limited our program to people who were within 2 years of the onset of psychosis. So our maximum DUP was effectively 24 months, because if it was more than that, then they weren't eligible. Okay. And again, these were very difficult decisions to make, but they were made between us, really by the state leadership. Okay. What was our strategy? Again, it was our eligibility. We focused on post-help seeking. We funded and monitored outreach activities. In other words, if you're going to ask programs to do something, you have to give them money to do it, and you also have to make sure they're doing it. And that is a theme of the whole program. Give people the resources, but don't assume they're doing it. You have to check. And now more recently, New York is in a Medicaid managed care transformation, so we're working with MCOs. In fact, the contracts between the state and the MCOs stipulated requirements around early psychosis care. So that's how you really get things done, right? Is you've got to get it into the contracts and into the legislation. And now more so than we were at the beginning, we're working with youth and social media. Okay, so here's just some data. So you can see 41% of our referrals have come from psychiatric inpatient units, 25% from outpatient mental health programs, 21% from families. And so you see, you know, this was not surprising. We were going to get more of our referrals from the mental health system. You can see that only about 22% of our referrals turned out to be eligible. So this is another issue that you have to think about if you're mounting this kind of program, is most of the people who are referred, because people don't know, you know, what it really looks like. I mean, psychosis is actually not that easy for non-professionals to kind of recognize, and even for professionals sometimes, particularly in the child world when they don't see a lot of psychosis, right? So, you know, we had to know what to do for people who were ineligible. You know what, I'm running short on time, so I'm not going to talk about this. Just to say that the likelihood of eligibility was greater from in the referrals from the mental health system. So more of the self and family referrals were not eligible, and that again was not surprising. Another strategy to identify people was using Medicaid claims. So we bothered Greg Simon, but we also borrowed Greg Simon's algorithm, and we went to see if we could identify people in Medicaid claims. Now, our program included all comers. You could have private insurance, Medicaid. So this is only applicable to the Medicaid, people on Medicaid. But one of the first things that we did was we used the algorithm, and then we wanted to see if we could find our on-track clients in Medicaid. Would the algorithm pick up people who we were treating? And so we were confident we're actually eligible. And that was, in fact, the case. Almost everyone that we were seeing would have been picked up by the algorithm. It's interesting. Then we were able to say, okay, we looked at the date that they would have been detected in Medicaid. And then we looked to see, well, how much earlier had their first onset, had their onset been, looking at, you know, because we were seeing these patients, and it was about 3 months. So Medicaid, you know, if we could, you know, based on this, you know, we'd only lose 3 months, which wouldn't be too bad. And then, but if we could pick up people at the time that they showed up in Medicaid, and then it was about 165 days after they showed up in Medicaid that they turned out to be working with us. Okay, and what you see here is, so we look to see where did they first show up. Did they show up in mental health, or did they show up in primary care? Or did they show up in substance use? And most of them showed up in mental health. Okay, so future work, we're doing a lot of different stuff around detection, but detection before. Our average DUP is about 7 months with a standard deviation of 5, okay? All right, now let's talk about the during. The during is the actual care. It's the coordinated specialty care, okay? And you've already seen this. You know what the program includes. I'm going to show you some data. You've already seen some data from John's study. This is retention. So here you have retention in Navigate, in community care. This is retention in Navigate. Again, you've seen these. So I'm just to show you that, again, there is a science here. This is another study from Vinod Trihari's group at Yale, another coordinated specialty care type of study, and you see reduction in hospitalization in STEP, which was their CSU model. This is reduction in hospitalization in usual treatment. This is vocational engagement in STEP, before and after. This is vocational engagement in usual care. So again, you know, this is pretty robust, this model, if again, the intervention is done correctly. There's some more debate about whether the model decreases hospitalization. This is a meta-analysis showing, in fact, that it does, but in the RAISE-ETP study, there was no difference in hospitalization between Navigate and control. So now I'm going to share with you a little bit about about OnTrack and our outcomes. So again, you've seen that our eligibility is basically non-affective psychosis or psychosis NOS, duration of illness duration of psychosis greater than 1 week, less than 2 years, age is 16 to 30. So all our sites had to be willing to cross that child and adult divide. This is the basic model. Outreach and engagement, sort of touching all the model components, which are You've already seen, we chose to, we wanted to underline suicide prevention, which again is a really big issue. This is a population at high risk for suicide. And SUD here stands for substance use disorder. Now we have peer support, so we have a half-time peer support counselor on all our teams. So we started out with 4 programs in the downstate area. Then we added, when this was funded by state dollars, then when we got the first set aside, we added like 10 programs, and this is where we are now. We have 22 programs. And you'll notice that they tend to be, we're sort of equally divided upstate and downstate, and we're in population centers upstate, although, you know, we do touch, you know, we all, both Washington State and New York State have the problem of how we're going to provide this kind of service to individuals living in rural areas. And that's a whole other conversation, but you obviously wouldn't put together a team that can serve 50 patients. I mean, it just, you know, wouldn't make any sense, because, you know, the incidence of schizophrenia, you know, there's some debate about it, particularly with Greg's data, but, you know, most studies find somewhere between, you know, around 10 to 20 per 100,000. So if you have a town like Binghamton, which is 40,000 people, you know, you just wouldn't make sense to build a team that can serve 40 people. So you got to think about it differently. Okay. All right. So this is where we are right now. Actually, I have the data from October. If I'd been able to use my computer, I would have pulled this data up in real time from the database that we have. So all these programs, they get money, but if they're going to get money, they have to do 2 things. They have to supply data, and they have to participate in technical assistance. So that's the deal. And we're all one big happy family. So you see here, we have mean age 21, predominantly male, and this is very typical of coordinated specialty care programs across the country. We're very diverse in New York State. 85% of our young people live with families, 6% were homeless, and again, the time since the onset of psychosis was 7.4 months. This is our treatment retention over time, so baseline 100%, 96, 90, et cetera. So these are every 3-month assessments. This is actually one of the few slides that I'm going to show you from OnTrack that actually is properly done by a statistician. And we have this article under review. This shows hospitalization rates at baseline. So most of our patients had a hospitalization or one or more in the previous 3 months before they enrolled. So we were working in the mental health system. The nice thing about getting people who were previously hospitalized is that it's much easier to show a cost savings for what it's worth. I mean, for the patient's sake, we'd much rather move the enrollment before they get hospitalized, right? So you see here, you know, robust reductions. Of course, you know, we don't have a control group here, so you can't draw real inferences. All you can say is, you know, these are our observations, and it's consistent with the randomized trials. This slide shows you actually rates of participation in work and school. I have to spend a minute on this slide because this is so important clinically. So, you know, you look at all this cross-sectional data, you know, hospitalizations in the last 3 months, but what really, the way we think clinically is we think across time, don't we? We think about patients and their histories and who they are. So what this slide shows you is it's each sort of horizontal line is a person, okay? And the black is not in the hospital, and the gray, black is, I'm sorry, in the hospital, and the gray is not in the hospital. So this is at baseline. What you see here is about, you know, 30% of our folks or 20% were not in the hospital, and the rest were, you know, 3 months prior to enrollment. And then what you see here is that all of this group of people, this red, were people who weren't hospitalized at enrollment, and they were never hospitalized at the follow-up times up to 1 year. This group of people, this light blue, are people who quote unquote improved. Most of them were hospitalized at enrollment, but then weren't hospitalized afterwards, okay? And we had a couple of people who were hospitalized at enrollment and then during the first 3 months and then never hospitalized. And then you have this very small group who were hospitalized at every time point. And then you have this sort of mishmash of groups. But the idea here is, what I want you to see is that we have great heterogeneity here. And I'm going to show you a slide. I won't walk you through it, but it's the same thing for school and work. And you'll see that there's a cohort of people who were never in school or work in spite of these rich services. And we have a cohort who were in school or work at every time point. And then there was, then there was a substantial cohort who weren't at baseline and then were. And so, but the point is, we're talking about schizophrenia here. We're not talking about a homogeneous illness. And so I think personally that one of the next scientific things we need to do is to sort of look at these groups and look at how different people have benefited or not. And then that's how we have to think about what comes next. Okay. These are Myrick-Gaff scores, again, going up. This is percentage of people in work and school. Once again, this is that slide of, this is in school and work at all time points. This is at no time points. So this is the minority of people. But there was a subgroup of people who just never made it to work or school. And I don't think they should just get more of the same. I think we have to think about them differently. Okay. And this finally, this is a slide, we actually, this is in press in the American Journal. It's a letter to the editor. It's very hard, this is hard stuff when you're not doing controlled work. You're just doing stuff in the community. It's a little harder to get it published, and we're working at it. But this shows you the percentage of people and modeling getting on Social Security, SSI, or SSDI. And so one of our goals was to prevent disability. And so you see here, looking at our data, that we had about, at 2 years, we'd estimate about a 20% rate of enrollment in SSI and SSDI. And it's very interesting because the RAISE ETP study, John's study, they were more at like 50%. They started out higher with a greater percentage of people on SSI, SSDI, and they added quite a bit more. And we think that there's probably a couple of reasons. One is their sample was different, but also they were in states where it might have been necessary to get SSI or SSDI to get Medicaid. And in New York State, these people are guaranteed service, regardless of their Medicaid status. So there was no incentive, or, I mean, there's always some incentive, but there was no access to treatment incentive to go on SSI, SSDI. And so, I was talking to Bob Heinzen about this, that, he thinks this is a very important piece of policy data. I mean, obviously some of the folks really were appropriate to pursue disability, but only a minority. Okay. Just so you see, we track, process things like prescribed antipsychotic medication. Of course, all of these people would have an indication for antipsychotic medication, but we practice shared decision-making. And if I were to see 100%, I would know they weren't practicing shared decision-making, okay? And this is percentage of patients with family contact. So again, I think, I'm pleased to see that, we're engaging families. Most of these folks live with their families. Okay. Many, many gaps: role of peers, cognition, suicidality, trauma. I mean, there is so much more to be done. And I think you could see from the data that, we haven't solved this by any stretch. And I know you didn't really think we did, but, we can really, I think a very big issue here is that this model really hasn't integrated an approach to cognition, which is, a number of us are trying to do that. Okay. I don't have to go over this. Okay, so finally, the last piece, which is the shortest piece, is what about afterwards? What do we know about what comes next? If in fact this is about changing trajectory, have we? Do we have evidence that we're changing the trajectory? And I'm going to tell you the short answer is no. No. Okay. So if you look at the literature that comes out of Europe and out of Australia, this is the Leo study, 18-month differences, no differences at 5 years. So without, ongoing treatment with the treatment model, the differences between the experimental group and the control group at 5 years went away. This is the OPUS study. It's the biggest study in, I always get my Scandinavian countries confused. I think it's in Norway. Anyway, big study. Differences between the OPUS, which was their experimental condition, and control at 2 years and 5 years, but not at 10 years, okay? So you see here the coming together of the treatment groups. Okay, what are the explanations around OPUS? I actually think this is, maybe the treatment wasn't long enough, absence of critical pieces. They didn't have supported employment and education in their model. And what I think is very interesting is that the average DUP was quite long. So maybe, if you remember John's slide where we saw the interaction between DUP and outcome, maybe, there was a problem with missing the critical time. I don't know. 2 more studies inform this. This is a study done in Hong Kong, 2 years of their early psychosis program called EASY. After the end of it, they randomized patients to either get another year of EASY and usual care, and the people who got EASY did way better. So the benefits persisted as long as the treatment persisted, okay? And then they, what they did was they then, after that year, they followed, everybody just got usual care and the differences came back together. So that there was no differences. So, you know, maybe people just need ongoing, really good care. Okay. Maybe that's what we've learned after all these years of studying schizophrenia care, that people need evidence-based practices adapted for who they are and their life stage. The study done in Canada, Ashok Malla, leader in this field, they also had 2 years of treatment of their early psychosis treatment, and they randomized people to 3 years of ongoing PEP and 3 years of usual care. And the people who got PEP had greater remission, negative positive remission, and so I mean they didn't have all the functioning measures and stuff, but again this study again provided evidence for the benefits of ongoing care. So you know, where does that leave us in OnTrack? You know, we are a 2-year program, or I should say, as I was saying earlier, I tell our teams, we say our length of stay should be an average of 2 years, meaning that some people are longer and some people are shorter. But, you know, I don't like this. I don't like it at all, because I feel like we're not, you know, what is the data teaching us? The data is teaching us that we can't just give this and take it away. We have to work with people, and our system, I can tell you in New York, it's not set up to provide this in an ongoing way. And so this is my last slide. What have we learned? What are the long list of challenges? And I actually, because I was thinking in terms of implementation science, I framed our challenges in terms of re-aim, okay? So if we think of re-aim as reach, what that means is we need to, you know, we're reaching some of the people, but we need to develop more effective strategies to reduce DUP and reach the community and reach the people who need it. In terms of effectiveness, we need to optimize the model. We're not there yet. In terms of adoption, we need to develop and train the workforce, and we need to think about how to deploy this across a population. In terms of implementation, we need to think about fidelity. There really is no validated fidelity scale. And in terms of maintenance, we need to, you know, that's all about solidifying the financing model. And then in terms of maintenance for the person, we need to think about transition and ongoing care. Thank you. Thanks. So, right, so I'm done.
On your
Questions?
slide with
Yeah.
Duration of untreated psychosis. Was there a difference with negative symptoms? Was that on the other side of the line?
You know, it's a great question, and you know, it's a little bit more iffy, but it's not consistently. In other words, negative symptoms also improved with shorter DUP, but then this is where I think it may be more confounded. So people with more negative symptoms may be having a longer DUP. And I'm sorry I didn't leave time for a lot of questions, but yeah.
And
Okay.
there are days here in Seattle that seems like every mental health patient uses cannabis. I'm just wondering
Yeah.
what you found in your
Yeah. So the quick answer on that is a lot of first episode patients everywhere use cannabis, but maybe more here, I understand from what I've heard. But I mean, it's an issue all over the world. And here's the short answer about what we know. We know that for people with mild to moderate use, just really, you know, decent stage-based treatment, harm reduction, good integrated care will not interfere with outcomes. Okay, and in fact, you know, some people say that people who smoke pot are kind of have better prognosis because they're more active, you know, and they're not negative symptom, whatever. But at a certain point with more severe use, honestly, I haven't seen any evidence that that we can get the outcomes. And so I think we're now in a situation where we know pretty much what to do, again, for people with mild to moderate use, but we're seeing, and as I'm sure you are, people with much more severe use. And we have to kind of rethink about that. I don't think we have the answer. Any other questions? Yeah.
Are you somebody in the role of advocating at the New York legislature level, for instance, to kind of argue like why we might want to continue to provide high quality services throughout the lifespan?
Well, I mean, the Office of Mental Health that I work for is an amazing group. I mean, I feel lucky every day that I come to work, truly, that we have such support. And, you know, it's a fight every day. But I think I will tell you that as a sort of a tool for hope and a tool for, you know, leading the way in terms of recruiting resources, these programs and these stories, when we get these videos out on the web, you're just gonna be like, this is amazing. I mean, the people telling their own stories. So it really engages people. Now, and now I'm thinking of a psych services article. There's a psych services article by Colleen Berry and a group at Hopkins that reviews communication strategies and effects on policy. Like, so what do we know? What does the research tell us about communication strategies and how they affect stigma and how they affect people's perceptions and people's opinions about public policy? And what that article shows is that there are two things that are necessary to influence people's opinions about public policy in the public policy debate. One is, you know, real human stories, you know, and contact. But the other is information about the structural barriers to care. So you can have the stories, but that alone might reduce stigma, but it's insufficient to change people's perspective. So I know I'm digressing from your question. I actually personally haven't testified before, you know, in our legislature, but I've actually been in other states. I've done that, but it's you know, it's sort of like you got to get your team together, you know, and in our state, there are, you know, our commissioner does that, and then we provide the information and the material, and it's way better to have a person with illness who's benefited. Like, they're the most powerful testifiers. Yeah.
What would you say would be an appropriate goal for DUP?
What,
you would be happy with?
An appropriate goal for DUP? I think, you know, we're looking at like 3 months is the goal, like the WHO and all of that. So, but you know, I am you know, I'm a cup is half full person. You know, I just feel like that is the goal, but you know, we can get it to 6 months, and that'd be way better than, you know, what we're doing now. So if we could get it to 3 months, that would be awesome. I think at a certain point, we actually have to get to the community and community education. And you know, if you look at the effective, you know, the research on reducing DUP, you know, there's a TIP study that was done in Norway. I get my Scandinavian countries confused, but there's Vinod Trihari, the guy at Yale, whose data I showed you from STEP. They have an R01, an NIMH-funded R01, to essentially replicate TIPS, which is community education and rapid access to services. And so they're doing that in the New Haven region, and their control condition, I love this, is Harvard, is up in Boston. So we'll see, you know, whether they can actually reduce DUP, and I've seen some of the early results, and they can, and then whether that's going to translate to better outcomes. Yeah.
Like, as far as community education, does that include schools as well?
Yeah, yeah. I mean, the trick about this is that, and we, you know, when we were designing our outreach programs and On Track, the problem with you know, the schools is that where you're doing an information campaign just on psychosis, is that it's not common. And so, you know, you have a guidance counselor with you know, who may see 1 or 2 cases like in a year, and it's very, you know, then it's complex because they don't see it enough to really learn it, and they don't see it enough to have algorithms. So Howard Goldman, who was a Ray's investigator, his wife is a guidance counselor at a high school in the Washington, D.C. area. And, you know, like, as he was saying, there's just no way that, given the lowish incidence relative to like depression and ADHD and all the other things that happen to teenagers, it's hard to kind of institute a program that is going to, you know, it's going to stick and be effective. But I mean, it's been done, and you know, maybe what it means is you join, you know, you don't just do a psychosis information campaign, you do sort of a, you know, school-based mental health campaign. And then, you know, then you go into the clinical high risk area. So do you say, okay, we're not just going to focus on psychosis, but, you know, we have this whole, you know, constellation of symptoms that, you know, where young people are quote unquote at risk for psychosis. Turns out most of them don't get psychosis, but they do have problems. And so, you know, you got to think strategically, I think, with your community as to how you're going to do these information campaigns in the schools, because, you know, you can't really be by yourself as, you know, teaching about psychosis. And I think there was another question.
Well,
Yeah.
yeah, so you mentioned that there's a lot of factors, of course, that are associated with treatment outcome. But could you go out on a limb and say if you think one of them or a couple of them are more important than other things?
You know, in terms of DUP or?
Not DUP, but as far as outcome.
Oh. God. I mean, you know, always the most robust predictor of outcome is premorbid, you know, is condition at enrollment. So if you work in school at enrollment, you're more likely to be in work in school. If you're, you know, I think we had some of those data, and we'll have that in our paper. So, you know, I mean, I other than, you know, long DUP as being, you know, pretty consistent predictor, I mean, sometimes, again, drug use can go either way. You know, it can, sometimes people look better if they stop.
What about within the treatment program? Is there any factor, I think, within the treatment program that's really seems to be,
yeah, well, like if we look actually in our data, I'm trying to remember, predictors of hospitalization were greater baseline symptoms, but I didn't include all these slides, but again, I really think the most parsimonious answer would be condition at baseline. I know it's almost a little disappointing, but that is, I think, I mean, and men always do worse. Yeah.
Doesn't New York State have a state community clinic so that when these patients are captured in these hospitals, they have a clinic that they can be followed up in? And so isn't that amazing?
Having a clinic that you can be followed up in is not the same as having, I mean, really, I mean, you know, I got to tell you, and you guys will see this, I mean, this is really hard work. It is really, really hard work. And you need really good clinicians, because you need a clinician that can deal with a psychotic person who you think might kill somebody, all right, or kill themselves, or they're, you know, very ill. I'm being dramatic, okay? Because these young people can get really, I mean, they're very sick, particularly when we first meet with them. And they don't know what's going on, and you don't know, you know, their families don't know what's going on. But then you have to be able to see that person as going to the prom, okay? Like, you have to be able to see their recovery. And so, you know, I mean, I don't want to speak ill of New York State programs or whatever, but like, I mean, let's put it this way. You're a 21-year-old, you walk into any of these programs in New York State and you see a bunch of 50-year-olds sitting in the waiting area. That's not where they want to be. So let's just start with that, okay? And I'm in that age group, just for another year. Yeah. So, you know, there's just right. There's just there's a lot of things that have to happen to make this, you know, this program work. And again, I don't want to overstate.
But that is infrastructure, though.
Yeah. Yeah.
Even, I mean, infrastructure, honestly, we don't have.
Yeah. Well, I mean, that may be true, and I can't speak to that, but you know, sometimes it's better to start from scratch than to have to undo things and fix it. Okay. Yeah, there you go. I told you I'm a cup half full person. But seriously, I mean, this is, you know, look, I mean, I'm a psychiatrist. I have a brother who's as sick as you're ever going to see. I mean, he's really sick, okay? And so I am not naive about what mental illness can be. But, you know, you know, to do this work, you really have to have a recovery orientation. And I think people who work in the system for a long time, it's very hard. It's very hard to do that, because we see people when they're at their sickest. You know, we see the sickest when they're at their sickest, right? And so and this is why we need to have consumers, and this is why we need to like surround ourselves with this community that sort of can keep this, you know, this orientation going. And it's just not easy. And we do training, my center does training, you know, in ACT teams and IPS, we train in a lot of different practices. And, you know, it is hard work, especially when you have clinicians who are, you know, not getting particularly well paid, and, you know, they have productivity standards and all that. So it's hard. Yeah.
Is it difficult to find sites that could bridge like minors and adults?
Oh, that's a great, yeah, interesting. So the whole site selection thing. You know, once people hear about this, everybody wants to do it. I mean, really, truly, like you know, say I've been doing evidence-based practice dissemination for almost 30 years, and I was like not popular. Okay, now I'm like popular. You know, like, you know. I mean, you know, that this is an easy sell. And so, you know, in other words, it makes so much sense to people to do this. So that, you know, I don't think there was a single, you know, every agency was, you know, they could get the, you know, the waiver or whatever, you know, you had to, for licensing and all of that, you have to do the, you know, go by the rules, and you know, you have to, and the state was willing to do the various exceptions that they needed to do to have children and adults together. So no, it really wasn't hard. And now, like I say, everybody wants to do it. And so actually now we have a problem where, you know, all right, how, you know, what do we need? What capacity do we need for the population? And how can we get there on basically the same amount of money? So, yeah.
For the QALS slide and hand slide, the navigate, the 0 time point was worse from both those things that for the navigate.
Yeah,
and
yeah.
Better. I didn't know if that was somehow done with like patient selection, low sensitive pre-randomized.
Yeah, this is what happens when you do site level randomization. I mean, so they didn't have patient level randomization, which, I mean, you can still get unequal baselines with patient level randomization, but it's a little bit more of a risk when you're doing site level randomization. And so all I can tell you is that, and I am not a statistician, and so like I skip the statistics section when I read papers, but I'm sorry. But this is why we need good statisticians that we can rely on. They, you know, clearly had to adjust for those kind of things, but it's unfortunate that.
You don't have as many sites as for busted data set per site.
Right. So you have, yeah, I mean, they did randomize the sites, but they had only basically 34. They didn't enter 34.
The vector is a lot better.
Yeah. Yeah, well, there you go. I actually know what a derivative is. At one point, I actually used that word in a sentence, but not now.
Sorry, yeah.
I mean, you know, there's a little bit of hocus pocus. Like, you read these statistics sections, and you know, you kind of have to like suspend disbelief, kind of.
I didn't know if it was like behavior, like people begrudge the initial treatment, but they more so look for the.
Yeah, no, it was just you know, I mean, the other thing about the Navigate study you have to understand is that like they didn't really do a lot of outreach. In other words, it was more just like who came to the clinic, and you know, the processes, you know, they were testing coordinated specialty care. They were not testing a strategy to reduce DUP, except to the extent that providing good service will reduce dropout, and then that will reduce DUP. But they're really two separate activities. And I think there's actually a fair amount of muddy thinking out there about this. So they did not have really specific strategies, activities to shorten the DUP independent of delivering the coordinated specialty care. And so, you know, that's one reason I think why their DUP, like our DUP is a little shorter, because of our 2-year thing, but also we're very deliberately doing stuff to try to reduce the DUP, and we're not even doing that much. Yeah. Okay. All right. Thank you.
Thank you.
I actually want to introduce myself. My name is Nancy Eisenberg, and I